Episode 23 Proximal Control Vascular Surgery Exam Prep. A continuation on descending thoracic aorta, inflammatory and genetic disease, and also aortic arch disease. FRCS and European Board Vascular Surgery Exam Focused Teaching. Welcome back to Proximal Control. I'm your host, Momia. This is the podcast where we prepare for the vascular exams the same way we practice as a day one consultant, with structure, judgment, and control, because in vascular surgery, control is everything. Alright, welcome back to Proximal Control. This is high-yield revision episode as a continuation of the previous episode on descending thoracic aorta, inflammatory and genetic disease, and aortic arch disease. We will also practice some rapid-fire questions and clinical scenarios at the end. So let's begin with inflammatory disease and genetic syndrome, as well as coarctation of the aorta. Vasculitis, that two conditions you must know for the descending thoracic aorta. Two forms of vasculitis are directly relevant to the thoracic aorta, and this is really important for the exam. One is Takayasu arteritis and the other one is giant cell arteritis. Let me take you through both, including the American College of Rheumatology diagnostic criteria, because these are important for the exam. Let's start with Takayasu arteritis, sometimes called pulseless disease. This is a large vessel granulomatous vasculitis causing massive intimal fibrosis. It can lead to either vascular stenosis or aneurysm formation in the thoracic aorta. Remember the epidemiology: 2 to 3 cases per million per year, 9 to 1 female predominance, and predominantly in Asian women. The clinical phases are important. There is an acute systemic phase with constitutional symptoms such as fever, fatigue, weight loss, followed by a chronic phase characterized by ischemic manifestation. For Takayasu arteritis, diagnosis requires 3 of the 6 ACR criteria. That is the American College of Rheumatology criteria. Age of onset, younger than 40 years, intermittent claudication, a diminished brachial artery pulse, a subclavian artery or aortic bruit, a systolic blood pressure variation of greater than 10 millimeters of mercury between the two arms, and angiographic evidence on CT or MRI of aortic or branch vessel stenosis. So remember these 6 criteria. If you have 3 of these 6 criteria, that's diagnostic for Takayasu arteritis. Okay, giant cell arteritis is very different epidemiological entity. The most common vasculitis in patients over 50 years. It affects Scandinavian population disproportionately, with a male to female ratio of approximately 2.5 to 1. It involves the aorta and its branches, with the aortic arch and descending thoracic aorta being the most commonly affected segments. A 50-year population study delivered important data. 31% of GCA patients develop large artery complications. Aortic aneurysm or dissection occurred in 18%. Large artery stenosis in 11%. When thoracic aortic dissection develops in GCA, the median survival from diagnosis is only 1.6 years. For giant cell arteritis, the diagnosis requires 3 of the 5 ACR criteria. And the sensitivity and specificity of this threshold are important numbers. Sensitivity 93.5% and specificity 91.2%. So you can see how important these criteria are. The 5 criteria are age 50 or older, new onset localized headache, temporal artery tenderness or decreased temporal artery pulse, ESR of 50 mm per hour or greater, and an abnormal arterial biopsy showing mononuclear infiltration or granulomatous inflammation. Treatment across both conditions starts with corticosteroid. In GCA, 30 to 40 mg per day, tapering to 10 mg by 6 months, then to 5 to 7.5 mg by 1 year. For refractory disease, methotrexate 15 to 25 mg per week or azathioprine 2 mg per kilogram per day. Tocilizumab, an interleukin-6 receptor antagonist, has demonstrated proven benefit for induction and maintenance of remission in GCA. Low-dose aspirin is recommended to reduce visual loss and stroke. One diagnostic practical point: if you start corticosteroids before performing a temporal artery biopsy, within 3 to 5 days the vessel wall inflammatory signals disappear on imaging and histology, giving a false negative result. Withhold steroids until after biopsy if clinically safe to do so. For Behçet's disease, the classic triad is recurrent aphthous ulcer, genital ulcer, and uveitis. The key surgical caveat: anastomotic pseudoaneurysm recurrence is very high after any vascular intervention due to the underlying friability of diseased arterial tissue. Immunosuppressive therapy must be established before and maintained after any surgical procedure. Avoid diagnostic angiography where possible, because arterial puncture sites can develop pseudoaneurysms in Behçet disease. So the ESVS guideline is clear here. Corticosteroids should be first-line treatment in patients with inflammatory disease associated with thoracic aortic disease. Higher dose corticosteroid and/or immunosuppressants should be considered before and after surgical intervention. Now let's talk about the genetic syndromes. When you're dealing with a patient who has connective tissue disorder, the rule changes. The threshold for intervention are lower. The risk profiles are different and the long-term follow-up strategy is more intensive. Marfan syndrome is caused by a mutation in the FBN1 gene on chromosome 15, encoding fibrillin 1. It's an autosomal dominant with an incidence of approximately 1 in 3 to 5,000. About a quarter of cases are spontaneous mutation with no familial history. Diagnosis uses the revised 2010 Ghent criteria, with greatest weight placed on aortic root aneurysm or dissection and ectopia lentis. The critical threshold for descending thoracic aortic repair in Marfan syndrome is 50 mm, lower than the 60 mm threshold in general population. Growth rate matters too. More than 2 millimeters per year is an indication for repair regardless of absolute diameter. Women and patients with other connective tissue disorders consider intervention at 50 to 55 millimeters. Avoid pregnancy if the aortic root exceeds 40 millimeter. Both beta blockers and ARBs slow the rate of aortic dilatation. Losartan has been shown in trials to have similar efficacy to atenolol. Loeys-Dietz syndrome, caused by mutation of TGF-BR1 or TGF-BR2, has 4 defining features: arterial tortuosity, hypertelorism, bifid or broad uvula, and aneurysms. Its cardiovascular course is aggressive. The mean age at first dissection is 26 years. Dissection has been reported at aortic diameter as small as 39 millimeters. The median age of death is 37 years. Intervention thresholds are therefore lower than Marfan. Aortic root and abdominal aorta greater than 40 millimeter, descending thoracic aorta greater than 50 millimeters, or growth rate greater than 5 millimeters per year at any site. Vascular Ehlers-Danlos syndrome, the type formerly designated type 4, is autosomal dominant and characterized by easy bruising, joint hypermobility, skin hyperelasticity, and critically spontaneous arterial rupture that may occur without any preceding aneurysms. The average age for the first major arterial or gastrointestinal complication is 23 years. Life expectancy is only 48 years. Maternal mortality during pregnancy is approximately 12%. From uterine or vascular rupture, which is why cesarean section should be planned before the onset of labor. The pharmacological intervention of choice is celiprolol, a beta-1 antagonist with beta-2 agonist properties, which was shown in a multicenter randomized blinded trial to prevent dissection and arterial ruptures in vascular Ehlers-Danlos. This carries a Class 2A recommendation. Turner syndrome involves partial or complete absence of one sex chromosome. It occurs in 1 in 200 conceptions but only 1 in 2,000 live female births. The majority are lost in the first trimester. The median age of onset of aortic dissection or rupture in Turner syndrome is 35 years. The annual incidence of aortic dissection in women aged 20 to 40 with Turner syndrome is 73 to 78 per 100,000. Compare this to the general Danish population where the incidence of aortic dissection is 6 per 100,000. That's more than a 10-fold increase. Baseline cardiovascular evaluation at diagnosis should include both MRI and echocardiography, repeated every 5 to 10 years or sooner if risk factors emerge, such as pregnancy, hypertension, bicuspid aortic valve, or coarctation. So, the ESVS guideline recommends in patients with genetic syndrome and thoracic aortic aneurysm, 50 millimeters or greater surgery should be considered. Celiprolol should be considered in vascular Ehlers-Danlos to prevent dissection and arterial ruptures. Reproductive health counseling by genetic specialists should be offered to all patients with a confirmed genetic connective tissue disorder. Okay, now let's talk about the aortic coarctation. Coarctation of the aorta is a congenital stricture at the level of the ligament arteriosum, just distal to the left subclavian artery. It affects males twice as often as females. The clinical picture is upper limb hypertension with weak, delayed femoral pulses, that is radiofemoral delay, lower limb claudication, and a systolic murmur in advanced disease, heart failure, or intracranial hemorrhage. What happens without treatment? The natural history is unforgiving. Mortality is 25% by age 20, 50% by the age 32, and 75% by the age 46. Most patients die of heart failure, acute aortic syndrome, premature coronary artery disease, or cerebral events. These numbers make intervention mandatory in almost all cases where obstruction is hemodynamically significant. Indications for repair is symptomatic patients in all cases, asymptomatic patients with a transcoarctation gradient greater than 20 mm of mercury at rest, or persistent upper limb hypertension, systolic greater than 140 or diastolic greater than 90 mm of mercury. After successful repair, hypertension resolves in approximately 2/3 of patients. Endovascular repair, especially stent replacement rather than balloon dilatation alone, reduces late complications including restenosis and aneurysm formation. Aneurysm formation after simple balloon dilatation occurs in 0 to 12%. For recoarctation, endovascular first is the preferred approach. So as per the ESVS guideline, open or endovascular repair should be performed in patients with coarctation with clinical manifestation from LV dysfunction, severe hypertension, or lower limb ischemia. Anatomically suitable patients with native thoracic aortic coarctation, endovascular repair should be confirmed. Now let's talk about the surveillance. Before we leave the descending thoracic aortic section, let's consolidate the surveillance strategy because these intervals are directly tested in the exam. For acute type B dissection, managed conservatively, CT or MRI at 3 months, 6 months, and then annually. After 3 years of stability, and stability means no growth beyond 5 mm per year and diameter below 50 mm, you can extend intervals to every 2 to 3 years. The same schedule applies for IMH, PAU. For IMH, especially watch for extension of the hematoma, development of an associated ulcer or progressive pleural effusion. All of these warrant escalation. For descending thoracic aortic aneurysm and thoracoabdominal aortic aneurysm, first scan at 6 months, then 12 months, then annually after 3 stable years, every 2 to 3 years. For inflammatory aortic disease, CT or MRI combined with PET and serum inflammatory markers such as CRP and white cell at 3 months, 6 months, then annually. For connective tissue disorder, same schedule as acute type B aortic dissection, but flag at diameter 45 mm or growth 5 mm per year. Postoperative surveillance after open repair. After open repair, CT angiography at 6 months, then annual CT angio or MRI after 3 complication-free years, extend to every 2 to 3 years. The complications to watch for are graft infection, graft occlusion, anastomotic pseudoaneurysm, and para-anastomotic aneurysm. Now, post-TEVAR surveillance and endolic classification. Post-TEVAR surveillance is more intensive than after open repair because the stent graft creates its own set of complications that require active monitoring. The schedule is CT angio within the first month, then at 12 months, then annually, extending to every 2 to 3 years after 3 stable years. Now, endolic classification that you need to know. Type 1 endolic is the most dangerous. It is direct flow between the endograft and the aortic wall that you already know. Type 1A is the proximal endolic, or type 1B is the distal endolic. Type 1 endolic means the aneurysm sac is under systemic pressure. It requires prompt intervention. Type 2 endolic is flow into the sac from the branches such as lumbar arteries or inferior mesenteric arteries in the AAA and bronchial arteries or intercostal in the descending thoracic aorta. These are managed with serial surveillance. Intervention is triggered by sac enlargement beyond 10 mm. Type 3 endolic is flow through a defect in the stent graft fabric or at the junction of overlapping stent graft, as you already know. Like type 1, it means systemic pressure in the sac and prompt intervention is required. Type 4 is flow through the porosity of the graft material itself. This is now rare with the modern graft. So the ESVS guideline, any early or late type 1 or 3 endolic after endovascular repair of the descending thoracic aorta should undergo prompt intervention. Lifelong imaging follow-up with MRA or CTA should be considered for patients treated with endografts. Now let's talk about some key clinical trials. Before we move to the aortic arch, let's consider the clinical trials, the evidence that underpins the recommendation we have discussed. Let's start with the ADSORB trial. ADSORB is the acute dissection stent graft or best medical therapy. ADSORB was the first and to date the only randomized controlled trial conducted in uncomplicated acute type B aortic dissection. Let's be clear about what that means. Uncomplicated, these were hemodynamically stable patients with no malperfusion, no rupture, and no refractory pain, as mentioned earlier. Patients were randomized to TEVAR plus best medical therapy or best medical therapy alone. The primary endpoint was a composite of aorta-related mortality, aortic rupture, and disease progression on 1 year. And there's the important caveat. The trial was underpowered for mortality. It did not have the patient number to detect a mortality difference, and no significant mortality difference was found. So when examiner asks you whether TEVAR reduces mortality in uncomplicated AT-BAD, the honest answer is the adsorb could not tell us that. What adsorb did show, and this is the key findings, was that TEVAR produced significantly higher rates of complete false lumen thrombosis at 1 year compared with medical therapy alone. And false lumen thrombosis matters because it is the mechanism by which the aorta remodels and stabilizes. A patent pressurized false lumen is what drives late expansion, rupture, and the need for intervention. Adsorb demonstrated that TEVAR promotes the biological process we want even in the uncomplicated setting. This is the evidence base behind the Class 2B recommendation that early TEVAR may be considered selectively in uncomplicated AT-BAD. So the adsorb key points: only RCT in uncomplicated AT-BAD, not powered for mortality, no mortality difference detected. So TEVAR showed significantly higher false lumen thrombosis at 1 year, and this is the Class 2B recommendation for selective early TEVAR. Now, if we talk about the INSTEAD trial, INSTEAD addressed a different question and a different population. Where adsorb looked at the acute phase, INSTEAD looked at the subacute and chronic type B dissection. It randomized stable patients, again no malperfusion, no rupture, to TEVAR plus optimal medical therapy or optimal medical therapy alone. The primary endpoint was all-cause mortality at 2 years, and the result at 2 years was no statistically significant mortality difference there. So TEVAR did not reduce 2-year all-cause mortality in stable CT-BAD. For many at the time, this seemed to suggest TEVAR offered little benefit, but the story does not end at 2 years. The INSTEAD XL, which is the extension, followed the same cohort to 5 years, and at 5 years the picture changed substantially. All-cause mortality still did not reach statistical significance, 11.1% in the TEVAR group versus 19.3% in the medical therapy group, and the p-value was 0.13, which is not quite significant. But aorta-specific mortality at 5 years was 6.9% with TEVAR versus 19.3% with medical therapy, and that was statistically significant, and the p-value was equal to 0.04. Disease progression at 5 years was 27% in the TEVAR group versus 46% in the medical therapy group, significant at p-value equals 0.04. The lessons from INSTEAD and INSTEAD XL together is profound. The benefit of preemptive TEVAR in stable CT-BAD takes time to emerge. If you only look at 2 years, you will miss it. The benefit is primarily in aorta-specific survival and disease stabilization, not all-cause mortality, and it becomes evident at 5 years. This is the foundation for the Class 2A recommendation. Instead, key points: RCT in subacute or chronic type B dissection, no all-cause mortality benefit at 2 years, instead excel at 5 years. Aorta-specific mortality was 6.9 in TEVAR versus 19.3 in medical therapy, and the significant p-value was p.04. Disease progression 27% versus 46.1%, and with a p-value of 0.04, and that's why the ESVS Class 2A recommendation for TEVAR in uncomplicated CT-BAD in subacute phase. Now let's talk about the Virtue registry and the petticoat technique. The Virtue registry was prospective European multicenter registry, not a randomized trial, and that captured 50 patients treated with TEVAR for acute type B dissection, and it provides important real-world prospective outcome data to complement the trial evidence. At 30 days, mortality was 8%, stroke 8%, spinal cord ischemia 2%, and these figures contextualize the TEVAR risk in an acute dissection population. And so the petticoat technique and the acronym stands for provisional extension to induce complete attachment, is a composite device strategy. It combines a standard TEVAR stent graft to cover the proximal entry tier with an uncovered bare metal stent placed infradiaphragmatically to re-explant the true lumen throughout the abdominal aorta. The rationale is to treat visceral malperfusion in the abdomen where sealing the primary entry tear in the chest. Published result at 1 year: mortality 10%, stroke or TIA 7.5%, dissection progression 5%. Now let's talk about the IRAD, that is the International Registry of Acute Aortic Dissection. IRAD is not a trial again, it's prospective international registry that has been running for decades and forms the backbone of natural history data for aortic dissection. Several of the statistics you have heard throughout this podcast come directly from IRAD. The key registry finding for type B dissection: overall in hospital mortality approximately 13%, complicated AT-BAD treated conservatively, survival approximately 50%. The 3 IRAD predictors of in-hospital mortality in T-BAD are the ones we discussed: hypotension with an odd ratio of 23.8, absence of chest or back pain with an odd ratio of 3.5, and branch vessel involvement with an odd ratio of 2.9. Late IRAD data: mortality approaches 25% within 3 years of hospital discharge, and 5-year IRAD data demonstrated reduced mortality with TEVAR compared with medical management in uncomplicated acute type B aortic dissection, providing the observational evidence that supports the adsorb trial findings. Okay, next we start the aortic arch disease. This is the most anatomically complex segment of the thoracic aorta. To treat the great vessel arise from it, the brain depends on it, and the surgical and the endovascular techniques required to deal with arch pathology are among the most demanding in all of the vascular surgery. Let's start with some important terminology. The Ishimaro-Jones divide the thoracic aorta into numbered segments. Zone 0 is the segment of the ascending aorta. Zone 1 runs from the innominate artery to the left common carotid artery. Zone 2 is from the left common carotid to the left subclavian artery. Zone 3 begins 2 centimeters distal to the left subclavian artery. Zone 4 onwards is the descending thoracic aorta. When we describe where a stent graft lands, we use these zones. Arch morphology also matters enormously for TEVR planning. There are 3 arch types based on the position of the innominate artery relative to the outer and inner curvature of the arch. In a type 1 arch, all 3 great vessels originate at the same horizontal level as the outer curvature, and this is the most favorable anatomy. In a type 2 arch, the innominate artery originates between the outer and inner curvature planes. In the type 3 arch, the most challenging, the innominate artery originates below the horizontal plane of the inner curvature. The more angulated arch, the more difficult the guidewire device navigation and higher the risk of stroke from catheter manipulation. The non-A, non-B dissection concept is also important here. When the aortic arch is involved, either by the primary entry tear or by the retrograde extension of a dissection, but the ascending aorta is not involved, this is classified as a non-A, non-B, not classic type B. Its incidence is 11% of all acute dissection. In hospital, mortality overall is 9%, but in arch entry, patients who require emergency surgery, it reaches 37%. When do we treat arch aneurysms? Isolated aortic arch aneurysms are rare. Most arch pathology requiring treatment is extension of ascending or descending disease. But when an arch aneurysm does occur in isolation, the natural history data guides us. A 14-year single-center series of 45 patients demonstrated a mean growth rate of 2.5 millimeters per year with a wide range up to 16 millimeters per year. 22% of patients suffered rupture during follow-up, and here's the critical predictive variable. Aneurysms growing faster than 5.5 millimeters per year had a 67% likelihood of rupture. Those growing slower than 5.5 millimeters per year had only an 8.3% rupture likelihood. So the growth rate was the sole independent predictor of rupture. European Society of Vascular Surgery guideline says treatment of isolated arch aneurysm should be considered at a diameter of 55 millimeters. And that's a class 2A evidence. Okay, let's talk about the open repair and the frozen elephant trunk. Open aortic arch replacement requires cardiopulmonary bypass. hypothermic circulatory arrest, and meticulous cerebral protection, either selective antegrade cerebral perfusion or retrograde cerebral perfusion. The key principle for the distal anastomosis: aim for zone 2 wherever possible. This reduces hypothermic circulatory arrest time, make the anastomosis more accessible, facilitates hemostasis, and significantly reduces the risk of left recurrent laryngeal nerve palsy compared with zone 3 anastomosis. The frozen elephant trunk technique, which is FET, represents a paradigm shift in the management of complex thoracic aortic disease. It combines open arch replacement with simultaneous endovascular treatment of the proximal descending thoracic aorta, all in a single operation. The proximal component is sutured circumferentially to the arch, eliminating the risk of proximal endoleak. The distal stent graft component extends into the descending thoracic aorta, providing a landing zone for future distal extension if needed, whether surgical or endovascular. The FET technique was first used clinically by Masaki Kato in October 1994. With the report published in 1996, the available devices today include the eVita Open from Geotech, the Thoraflex Hybrid from Vascutech, and so on. In acute aortic dissection, false lumen thrombosis is achieved in more than 90% of patients following frozen elephant trunk. With progressive false lumen shrinkage and positive aortic remodeling on serial imaging, a systematic review found a spinal cord ischemia incidence of 5.1% following FET deployment. A Japanese comparison of 120 patients FET versus hemiarch replacement found mortality in the FET group of 4%, no new cerebral events, and 5-year survival of 95%, compared with 69% in the hemiarch group. When FET is combined with left subclavian artery debranching, all 3 arch vessels can be perfused during the entire arch repair, providing maximal cerebral and spinal cord protection. And the ESVS guideline clearly says FET or TVAR should be considered in acute type A dissection with primary entry in the distal arch or proximal DTA to prevent its postoperative development. Frozen elephant trunk should be considered in complicated acute type B dissection when endovascular intervention are contraindicated. Frozen elephant trunk is not recommended in connective tissue disease where the proximal landing zone is in native aortic tissue. Hybrid arch repair, that is debranching and TVAR. Hybrid arch repair avoids the need of circulatory arrest, cardiopulmonary bypass by first creating an adequate proximal landing zone through open extraanatomic debranching of the supraaortic vessels, followed by endovascular exclusion of the arch pathology. Zone 0 debranching, that is revascularize all 3 vessels. Zone 1 debranching revascularize the left common carotid and left subclavian. Zone 2 debranching revascularize the left subclavian only. The main advantage of hybrid repair is avoiding the hemodynamic burden of hypothermic circulatory arrest in patients whose cardiac function may not be whose cardiac function may not tolerate it. But there is an important caveat. For patients at high stroke risk, open arch surgery actually remains superior. The extensive catheter and wire manipulation required TEVAR delivery in the arch can mobilize atheromatous debris and cause embolic stroke. The hybrid approach trades one risk for another. Device requirements for hybrid TEVAR are non-negotiable. The proximal and distal landing zones must each by at least 25 mm in length. Measured on the inner curvature, the maximum aortic diameter must be below 38 mm, and at least one adequate access vessel must be available greater than 7 mm in diameter. So, just to recap again, access vessel must be available, at least one access vessel, and that needs to be greater than 7 mm, and we said proximal and distal landing zone must be at least 25 mm in length, and measured on the inner curvature, the maximum aortic diameter must be below 38 mm. There are three Class 3 recommendations from the 2019 consensus of the ESVS guideline. The first, if the ascending aorta diameter exceeds 38 mm, if there is a bicuspid aortic valve, or if the sinotubular junction is lost, open surgery is preferred over hybrid TEVAR because the risk of retrograde type A aortic dissection from the stent graft is too high. The second is the parallel grafts, also called chimney or snorkels, are not recommended as a routine elective strategy when other options are available. They are a bailout technique only. Third, stent graft deployment into zone 0 to 2 is not recommended in connective tissue disease patients, where the proximal landing zone is in native aortic tissue. So the ESVS recommends TEVAR in zone 1 and 2 should be considered in patients with suitable anatomy. In elective TEVAR zone 0 to 2, preventive left subclavian artery revascularization should be considered to reduce stroke and spinal cord ischemia. Hybrid aortic repair should be centralized in centers with expertise in both open and endovascular surgery. Now let's talk about total endovascular arch repair. The total endovascular arch replacement using fenestrated or branched stent graft is the frontier of aortic arch treatment. Both device types are currently custom manufactured with a lead time of 4 to 8 weeks, which means they cannot be used in urgent or emergency situation. Fenestrated arch endografts work by aligning windows in the graft fabric with the origins of the arch vessels. The Najuta graft, developed in Japan, reported in 363 patients, showed 30-day mortality of 1.6% and stroke of 1.8%, which are best published results for any endovascular arch device. The Zenith fenestrated arch graft from Cook is in early experience showed higher mortality up to 20% and stroke up to 14%. The relay scallop graft from Terumo showed mortality 5% and stroke 14%. Branched arch endograft use internal side branches rather than fenestrations and require less precise rotational control during deployment. The Zenith branch and graft reported 0% 30-day mortality and 11% stroke. The relay branch graft showed mortality 7% and disabling stroke 7%. The dominant challenge across all arch procedure, open or endovascular, remains a stroke. In endovascular arch repair, stroke rates range from 0 to 14%, as you have already seen. Mitigation strategies including flushing the delivery system with carbon dioxide, deploying filter devices in the carotid arteries, and minimizing catheter and wear manipulation within the arch can be applied. As we know, the mechanism of these strokes are mostly embolic from the arch manipulation or air emboli introduced from the delivery system. So the ESVS guideline is clear. Endovascular arch repair in zone 0 should be considered in patient unfit for open surgery with suitable anatomy. Stent graft deployment is not recommended when landing zone length is less than 25 mm or maximum diameter exceeds 38 mm. So let's summarize things now. If you want to take a summary from the whole discussion, including the previous episode, the normal descending thoracic aorta diameter mid aorta for men is 24 to 29 mm, women is 24 to 26 mm, and this tapers down to the diaphragm slightly. Epidemiology of the TBAD is 2.9 to 4 per 100,000. IMH is 5 to 10% of all acute aortic syndrome, 60% in descending thoracic aorta. That means most of the IMH, that is 60%, happens in descending thoracic aorta. Traumatic aortic injury is less than 1% of all motor vehicle accidents, but 16% of traumatic deaths. The classification, we talk about Stanford classification, that is type A, ascending aorta is involved regardless of the TR origin. Type B, no ascending and distal to the left subclavian. Acute type B aortic dissection is 30 to 40% of all aortic disease. Acute dissection is called when it's 0 to 14 days, subacute is 15 to 19 days, chronic is more than 90 days. Non-A, non-B aortic dissection when the arch is involved but ascending is not. And the incidence is 11%, mortality is 9%. Crawford classification, as we already said, these are the thoracoabdominal aortic aneurysm classification. Crawford type 1 is left subclavian to renals, type 2 LSA to iliac, and this has the highest spinal cord ischemia risk. Type 3 is T6 to iliacs, type 4 diaphragm to iliacs, and type 5 is below 6th intercostal space or T6 to just above the renals. Descending thoracic aorta extends. Type A proximal descending thoracic aortic aneurysm. Type A proximal descending thoracic aorta to the T6. Type B distal descending thoracic aorta from T6 Okay, I just say it again. Now, if we classify only descending thoracic aortic aneurysm according to the extension, type A extend proximal to descending thoracic aorta and ends to T6. Type B distal descending thoracic aorta from T6. So above the T6 it's type A, below the T6 it's type B, and the type C is entire descending thoracic aorta. So this is only descending thoracic aneurysm. Don't confuse with the Crawford classification of thoracoabdominal aortic aneurysm. Now, traumatic aortic injury, intimal tear, its conservative management. Now, blunt traumatic aortic injury, type 1 is intimal tear, that's conservative management. Type 2, that's IMH. Type 3 is pseudoaneurysm. Type 4 is the rupture. And type 3 and type 4 are the surgical management. Ishimaro zone, 0 is the ascending, 1 is innominate to the left common carotid, 2 is left common carotid to left subclavian, and 3 is 2 centimeter from the left subclavian, and 4 is descending thoracic aorta onwards. Arch type, there are 1, 2, and 3 by the position of the innominate, and as we said, the type 3 is the most difficult as innominate originate below the inner curvature plane. Now, the diameter threshold descending thoracic aortic aneurysm, you may treat at 56 to 59 millimeter. However, you should treat when it's more or equals to 60 millimeter. In women or connective tissue disease, you can consider 50 to 55 millimeter. Rupture escalates at 70 millimeter. Chronic type B aortic dissection may treat again 56 to 59 millimeter and should treat more than 60 millimeter. So it's the same, the descending thoracic aorta and chronic type B dissection may treat 56 to 59, should treat more than 60. Now, Marfans are different. You repair at more or equals to 50 millimeter, or if the growth rate is more than 2 millimeter per year. Remember, there is even the growth rate is only more than 2 millimeter per year, you still consider for repair. And avoid pregnancy if root is more than 40 millimeter. Loeys-Dietz syndrome, root or abdominal more than 40 millimeter, DTA more than 50 millimeter. So you consider in this case surgical intervention. Growth more than 5 millimeter per year, and then you also consider. So this here the growth is more than 5 millimeter per year for Loeys-Dietz. But you consider again for repair is more than 50 millimeter in Loeys-Dietz, same as Marfan for the descending thoracic aorta. Now just remember here the root and abdominal aorta, it's mentioned more than 40 millimeter for Loeys-Dietz. In Marfan it was mentioned more than 40 millimeter to avoid pregnancy if the root is more than 40 millimeter. Now PAU, consider early repair if the diameter is more than 20 millimeter or depth is more than 10 millimeter. This is very important to remember. Diameter more than 20 millimeter, depth more than 10 millimeter. Then you consider early repair for PAU. Isolated arch aneurysm, treat at 55 millimeter. Coarctation, repair if the gradient more than 20 millimeter mercury and the blood pressure in the upper limb is more than 140 over 90 millimeter. Now some important numbers to remember. In AT-BUD, that is acute type B aortic dissection, the blood pressure target systolic is 100 and 120 in between. Heart rate should be less than 60. And that IV beta blockers will be the first line. In chronic type B dissection, the blood pressure target systolic is less than 130 and the diastolic is less than 85. Beta blockers give 80% event-free survival at 4.2 years versus 47% without the beta blockers. So beta blockers are very important in chronic type B dissection. IMH, the beta blocker gives 95% survival, and that's again very important in IMH as well. Ehlers-Danlos vascular type celiprolol, this is a multicenter. In Ehlers-Danlos vascular type, celiprolol is recommended as per ESVS guideline, and this has been proven in multicenter RCT, and this prevents dissection and ruptures. Now, few important operative results. Complicated acute type B dissection, the TVAR, the technical success rate 95 to 99%, hospital mortality is 2.6 to 9.8%, and neurological complication is 0.6 to 3.1%. Rupture descending thoracic aneurysm, the TVAR 30-day mortality is 19% versus 33% in open. So you can see the TVAR is the most recommended option. In traumatic aortic injury, TVAR versus open repair mortality again 9.7 versus 27%. So again, the TVAR is indicated than open repair. And remember, if you do TVAR, oversizing should not exceed, you should not oversize more than 20%, and ideally it should be around 10%. So oversizing target should be around 10%, not high. Descending thoracic aortic aneurysm, TVAR versus open repair, again the TVAR gives 5.5 and the versus open repair gives 16.5% perioperative mortality. So you can see it's almost 1/3 of the open repair in descending thoracic aortic aneurysm. Same as blunt traumatic aortic aneurysm, TVAR also is 1/3, that is 9.7% mortality versus 27.7% mortality. So is 1/3. Now, some key trials we already mentioned about adsorb trial, only RCT, that's uncomplicated acute TBOD, not powered for mortality. However, TVAR showed higher false lumen thrombosis at 1 year. Instead is a chronic type B aortic dissection RCT, no all-cause mortality difference at 2 years. However, instead XL at 5 years, aorta-specific mortality again is almost 1/3 in TVAR, that is 6.9% versus 19% in medical therapy only. And the disease progression was 27% in TVAR, whereas 46% is only medical therapy. Now, spinal cord protection is another important thing to recap. CSF drainage reduces paraplegia by 75% and target the CSF pressure to keep less or equals to 10 mm, and that needs to be kept for 48 to 72 hours post-operatively. And as you remember, spinal cord perfusion pressure is MAP minus CSF or CVP. Again, spinal cord perfusion pressure is MAP minus CSF or CVP. Left heart bypass, spinal cord ischemia from 11% down to 4.5%. In thoracic aortic aneurysm, not recommended for isolated descending thoracic aortic aneurysm. So remember, left heart bypass is only type 1 and type 2 thoracoabdominal aortic aneurysm, but not for descending thoracic aortic aneurysm. Hypothermia less than 32 degree combined with CSF drainage not recommended. If you do hypothermia, it needs to be just 32 degree, not below 32 degree, because it will increase subdural bleeding. Left subclavian artery coverage increase the stroke rate, and the planned prophylactic left subclavian artery revascularization for all elective cases, and this is recommended. Delayed spinal cord ischemia after arch repair, secondary CSF drainage plus treatment bundle is recommended. Now, if you remember the vasculitis ACR criteria, we said Takayasu 3 of the 6 criteria, that is age less than 40, claudication, diminished brachial pulse, bruit, more than 10 mm blood pressure arm difference, and angiographic stenosis. Any 3 of these 6 criteria, then it's diagnostic for Takayasu. Again, I say these 6 criteria as it is really important. Age less than 40, claudication, diminished brachial pulse, bruit, more than 10 mm blood pressure arm difference, and angiographic stenosis. Now, giant cell arteritis, that is GCA, 3 out of 5 criteria, that is age more or equals to 50, headache, temporal artery tenderness or reduced pulse, ESR more or equals to 50, abnormal biopsy, and this 3 out of 5 is also diagnostic for GCA. Okay, I think now we will talk about the natural history of some of the connective tissue disease. If we say about Loeys-Dietz syndrome, the median age of death is 37 and the mean first dissection is 26. Ehlers-Danlos syndrome, vascular type, the first major event is at 23 and the life expectancy is 48 years. Maternal mortality in EDS in pregnancy around 12%. Now we are at the rapid fire questions, and that's relevant for you. Let's go. A 60-year-old woman present with severe chest pain, her GP refers her with a CTA showing type B aortic dissection. On the axial cuts, the right kidney is not visualized. Lactate is elevated, white cell raised, and the renal function is abnormal. What is the most appropriate management? You can see that there is malperfused with renal ischemia from dissection. This is an indication for TEVAR. So your answer would be TEVAR. Of course, blood pressure control will be there, but blood pressure control alone is insufficient when organ ischemia is established. Okay, next, a 55-year-old man with type B aortic dissection and severe hypertension has a CTA showing SMA and one renal artery arising from the false lumen with the contralateral kidney spared. What is the appropriate management? Control blood pressure, then TEVAR. In type B aortic dissection with visceral malperfusion, as we said already, optimize blood pressure with IV beta blockade first, then TEVAR to re-expand the true lumen if there is organ malperfusion. Okay, a TEVAR is planned with proximal landing zone of 1. What bypass is required to revascularize the covered vessel? Right CCA to left CCA to left subclavian artery bypass. Why? Because zone 1 coverage requires debranching both the left common carotid and left subclavian. The right CCA is used as an inflow, so you do right CCA to left CCA to left subclavian, and then only you can use the zone 1 coverage. If you remember, zone 1 is from the innominate to the left common carotid. Before that, it was zone 0. Innominate comes from the zone 0. So from it, after innominate to left common carotid is the zone 1. That means your right common carotid coming from the innominate will be the inflow. Okay, following TVAR, a 72-year-old woman develops weakness, loss of pain and temperature sensation but preserved proprioception. What is the diagnosis? This is an anterior spinal cord ischemia. Anterior spinal artery supplies the anterior two-thirds of the cord. Motor, pain and temperature. Proprioception is the dorsal column and that is spared. A 45-year-old woman, sustains a traumatic aortic transection with hemothorax following a road traffic accident. TVAR is not available. The injury is classified as grade 3. What is the appropriate time of intervention? This needs to be urgent but not immediate. By urgent, we mean 12 to 24 hours. Grade 3 aortic dissection is managed urgently within 12 to 24 hours. Open surgery if TVAR unavailable. Grade 4 is immediately managed because it's the complete transection. Okay. A thoracoabdominal aortic aneurysm is described on imaging starting from T6 with normal aorta at the level of the renal arteries with no information on diaphragm involvement. What Crawford classification is this? So you know that, as mentioned earlier, type 5 hangs between the thoracic 6 and the renal, and just above the renal it finishes. That means you have the diagnosis here. This is type 5, T6 to visceral aorta, not extending below the renal vessels. That's type 5. What does Crawford type 4 thoracoabdominal aneurysm mean? Type 4 involves the segment from the diaphragm to the aortic bifurcation, including visceral vessels. So it's purely abdominal. An MRI is requested for a patient who has a previous EVAR. A 62-year-old man with a known chronic type B aortic dissection is found to have an occluded celiac axis and a hepatic artery aneurysm. No endovascular option is feasible. What is the definitive treatment? In chronic dissection with occluded celiac and hepatic aneurysm where endovascular is not possible, you consider open surgical reconstruction. A 70-year-old man undergoes a postoperative ITU stay following ruptured AAA repair. He develops rising noradrenaline requirements. A 58-year-old man has a spinal cord perfusion pressure calculation required. Your blood pressure is given 90/50 and a CSF pressure is given 16 mm mercury. What would be your spinal cord perfusion pressure? So if you remember, the spinal cord perfusion pressure was MAP minus CSF pressure. So how would you calculate the MAP? As we all know, MAP is the diastolic pressure plus 1/3 of the pulse pressure, and the pulse pressure is the systolic minus diastolic pressure. So here the diastolic pressure is 50, so we will do the MAP is diastolic pressure plus, that is 50 plus 1/3 of pulse pressure, that is 1/3 of systolic minus diastolic, that is 90 minus 50, that is 40, and 1/3 of 40 will be almost 13. So we calculate diastolic pressure plus 1/3 of pulse pressure, that is we calculated just now 13, will be 50 plus 13, that is 63. So the MAP is 63. Now, the MAP minus CSF pressure will be the spinal cord perfusion pressure. So MAP is 63 minus your CSF pressure is 16. So the perfusion pressure will be 47 here. And the target spinal cord perfusion pressure is 60 to 80 millimeter mercury. So you need to increase the perfusion pressure by increasing the MAP. This is to remember that the target spinal cord perfusion pressure is 60 to 80. Following subclavian artery coverage during TEVAR, which structure is the greatest risk of ischemia if left subclavian revascularization is not performed in patient with a previous open AAA repair, and that's the spinal cord and anterior spinal artery. Previous open AAA repair sacrifices lumbar collaterals. Combined with left subclavian coverage, risk of anterior spinal ischemia and is significantly increased, an absolute indication for revascularization. Now, a 50-year-old man with type B aortic dissection is managed with intravenous antihypertensive therapy. Which agent is the first line? We know this is IV labetalol. A 52-year-old woman is found to have Takayasu's arteritis. What surgical option is most appropriate for her mid-aortic syndrome? So if somebody has mid-aortic syndrome with Takayasu's arteritis, the surgical option would be aortobirenal to revascularize both renal arteries. A 38-year-old woman, a painter and decorator, present with recurrent dizziness and unsteadiness at work. Thank you very much. We are at the end of this episode. Thanks for listening to Proximal Control Vascular Surgery Exam Prep. If you found this useful, stay tuned, because in the next episode we will discuss vascular trauma, very important topics for written as well as clinical and oral exam. We will cover these in 3 episodes to discuss detail about vascular trauma, including 2025 ESVS vascular trauma guidelines. As always, with your support, we will grow together. Keep listening to Proximal Control, because in vascular surgery, control is everything.